So today we have a slide seminar on the topic of inflammation and repair case-based studies. The presenter is Professor K.P. Aravindan sir. He is consultant pathologist, Kozhikode, District Cooperative Hospital, Calicut. Chairperson of today talk is Dr. Anita Boris ma'am. She is lab director and consultant pathologist, Center for Oncopathology, Mumbai. These are the participants for today talk. I request everyone, all the participants, to please introduce one by one, starting with Dr. Ankita. Yes, Dr. Ankita.
Respected faculty, I am Dr. Ankita Simhara, third year pathology resident from
Dr. Ankita, please introduce.
Ankita, we can't hear you.
We can't hear you, Ankita.
Hello, Ankita.
Yes, one.
Yes. Please introduce yourself.
We were hearing you very well a little while ago. Come on, Ankita.
Good evening, respected faculty. I am Dr. Ankita Simkhada, third year pathology resident from Institute of Medicine, Nepal.
Arifa. Dr.
Arifa?
Arifa.
Arifa is not there.
Oh, she's not there. Okay.
Dr. Monica.
Good evening, everyone. This is Monica, second year postgraduate from NRI Medical College, Andhra Pradesh.
Ashok.
Good evening, respected faculty. This is Dr. Ashok from NIMS, Hyderabad. Now, second year pathology resident.
Dr. Niti.
Good evening, everyone. This is Dr. Niyati, second year postgraduate student from Grand Government Medical College, Mumbai.
Vishnupriya.
Good evening, everyone. I am Dr. Vishnupriya, first year postgraduate, CES Medical College, Andhra Pradesh.
Dr.
Good
Lamia.
evening, everyone. This is Dr. Lamia Padma, first year postgraduate pathology, SIMS Hapur.
Welcome all of you. So today moderators are myself, Dr. Mohammed Tala, and Dr. Pooja Pijaria. She is ex-fellow in pathology and ex-senior resident fellow in Mumbai. Some reminder of the today talks. If you have any connection interruption, low or no sound, video freezing or video lag, kindly leave the meeting and rejoin the same link. If the same problem persists, please check the connector internet connection. Please answer the full question by typing the chat box. Please do not send the request for annotation to the presenter. These are the disclaimers. Before starting, I will have to remind about the upcoming talk on 20 July by the select seminar. The topic is utility of the immunohistochemical marker in the diagnosis of CNS tumor as per current WHO classification by Dr. Ipari Shirjar. He is from TMH Mumbai. And after that, we have on 25 July, how a pathologist can suspect an immunodeficiency by Dr. B. Saikia. Without wasting any time, let's start. Over to you, Aravindan sir.
Good evening to all of you. The topic is basically inflammation, which is a very vast subject. And I would say that probably all the histopathology material that we see, more than half would be inflammation. So necessarily, I would be very selective, and it will be just a few examples of inflammation. It will not be comprehensive in any way. With that, I think we will go to the cases. I think I will project the slides one by one, the slides that were shown to you, and I will call each of you in turn to discuss each case. And maybe you can just describe the slides as and when it is on the screen, what you see. Whatever you see, you just describe it. And finally, what is your impression regarding the diagnosis, what it is likely to be? So this is the way that we will go forward. So I'll start by sharing the screen. And for the first case, to discuss the first case, I'll call Ankita. Please discuss the first case
Yes, sir.
one by one, as and when you see the slides. The history is male, 29 years, history of chronic diarrhea. Ankita, please.
In this first slide, I think this is a low power view. I can see that this is a colonic tissue with partially ulcerated lining epithelium. In this slide, I can see that there is focal loss of crypts with the other crypts. They show normal columnar lining with normal preserved architecture and normal mucin.
Okay, so what do you think is the most striking feature in this slide? When compared to a normal colon, what would you think is the most striking feature?
Compared to a normal colon, I think there is focal loss of gland with the epithelium. I cannot see a proper epithelium there. And
The surface epithelium may not come in all biopsies. This is a mucosal biopsy. Sometimes the surface epithelium may not come, and it may look what may look as ulceration may not be real ulceration because the cut occurs below the epithelium. It may not be that, but something more. What do you think about the cellularity?
I think
Background cellularity.
I think that the cellularity, the crypts are lesser in number than in a normal colonic biopsy, and that there is some inflammation in the lamina propria, which is more than usual.
Okay. So I'm not really very sure about the number of crypts, whether it is less. I'm really not very, very sure in this particular slide. But there's no doubt that the laminal cellularity is really quite high. So that is the thing that you see in this. This is another view of this. So do you think the cellularity is high now?
So I think that the cellularity within the lamina propria is markedly increased.
Okay. And anything else that you see here, right at the center of the slide?
I think some of the crypts, they show branching along with mucin depletion.
Okay, there is mucin depletion. Agreed. There is goblet cell depletion. And anything else you center on the slide? This one that you see here.
There is crypt abscess, I think.
Yeah, there are inflammatory cells right within the crypt is there. And this is a higher power view. What do you think now?
Cryptitis, as well as there is the increased cellularity within the lamina propria.
Okay.
And on this high power view, I think there is some kind of regenerative atypia as well.
Okay, mild changes are there. What else? Are there cells creeping into the crypts? What do you call this?
This is cryptitis. There are neutrophils within the crypts.
So there is cryptitis. What are the kind of cells that you see here in the lamina
propria? I can see that there are some eosinophils, neutrophils, as well as plasma cells.
Okay. Neutrophils, eosinophils, and plasma cells seem to be increased. Here again, you see a crypt abscess nicely here. So with all this, what is your impression?
I think with all this, my impression would be of an active colitis, a diffuse active colitis.
Okay. In this slide, what do you see?
Well, I think, sir, that the lamina propria does not show marked inflammation that we saw in the previous slides.
Okay.
However, there is edema within the lamina propria.
Anything else?
I think there is, again, there is mucin depletion, and some of the crypts, they show slightly hyperchromatic nuclei with some stratification.
Hyperchromasia? No, this is okay. Actually, when there is goblet cell depletion, you may think that it's a bit darker than usual, So that is not real hyperchromasia. See here, normally the bottom of the crypts will touch the muscularis mucosa. But here there seems to be a big gap between the lower end of the crypt and the muscularis mucosa. And this is indicative of shortening of the crypts. And shortening of the crypts is a sign of chronicity. So sign of chronic disease. So you said that already there is an active colitis. In addition to the active colitis, there is also some sign of chronicity. And in this picture, what do you see?
I see that there is the crypt branching.
Yeah, very good. So there is a crypt branching, colitis and crypt branching, which is again another sign of chronicity. So when you find both active as well as such chronic lesions, what is the most likely diagnosis?
First is an inflammatory bowel disease.
Which one? Which one?
Ulcerative
When you see so much of chronicity, which is the likely diagnosis? Among the IBDs, the main ones are ulcerative colitis and Crohn's disease. So which one is more likely? With chronicity, it is more likely to be ulcerative colitis. And besides, you don't find other features of Crohn's like granulomas or anything, which of course need not be there always. But so here, I would say that this is a case of ulcerative colitis. Would you agree? So this seems to be a ulcerative colitis, and there is activity, as you said, which is severe because the crypt abscesses are there. There is some chronicity and not much of dysplastic changes. So this is basically what it is. So now from this, I will the main message here is that the cellular response, what kind of cells predominate in a lesion, inflammatory lesion, gives some clue regarding the clinical condition or the cause and ultimate diagnosis. Now I'll just give you a quiz, an MCQ. Can you answer this? I'm not making it into a poll, but I will ask directly to Ankita.
Plasma cell?
No, plasma cells can be seen normally in mucosal tissue. It's a normal resident cell of the mucosa. In fact, if you don't see any plasma cells in a mucosa, that's when you should be suspicious that it may be an immunodeficiency, a B cell immunodeficiency sometimes. Anybody else wants to volunteer?
Macrophages.
Macrophages are there almost everywhere in the body. It is a neutrophil. Eosinophils, lymphocytes, macrophages, plasma cells, all those can be seen in the mucosa, but you should not be seeing neutrophils except within the capillaries. Congested capillaries may contain eosinophils, but not outside. So it is not a tissue cell basically, and when you find neutrophils, it means that there is an active inflammation. Okay, so what are the mechanisms of when you find neutrophilic lesions in which you find neutrophils in the tissue? It can be acute inflammation due to various modes of injury, abscesses, and many other kinds of things. It may be due to an increase in pro-inflammatory cytokines, which may be due to inflammation. It may be even due to neoplasms, various causes. It can be due to vascular damage and leakage of the blood outside, like vasculitis. Typically, you find neutrophils getting out. Or there may be inciting foci or persistent organisms or immune complexes within the tissue, which is attracting the neutrophils towards that. So all these are the basic causes of neutrophils in the tissues. So whenever there is an inciting cause, these neutrophils will just marginate. This is what you have learned in basic inflammation classes. They will marginate and then they will emigrate out of these capillary vessels and come into the tissues when it becomes abnormal. Many examples like lobar pneumonia here, which we show these MBBS students, And this is an organism here with Splendor-Hopley phenomenon outside and surrounded by neutrophils. And certain types of organisms are particularly liable to attract neutrophils, like actinomycosis, for example. Even chronic actinomycotic lesions, you find neutrophils all around. Mycetomas, some fungal lesions, like they're called mycetomas. All these are typical examples of such lesions. Then you have immune complexes attracting neutrophils, like in the skin biopsy. This is one of the immune complex diseases, probably linear IgA dermatosis or some other cause, attracting neutrophils. And if you do a immunofluorescence, you will find that there are immune deposits here. And here you find, what do you find here, Ankita? There is inflammation. In addition to that, what do you find typically? You find a lot of nuclear dust. So particularly in when neutrophils migrate in vascular damage, many of them degenerate within the tissues and you find nuclear dust, which is called leukocytoclasia. Leukocytoclasia is just mostly degenerated neutrophils, and here you find some vascular damage. This is an example of a vasculitis. Here on one side you find what is called a neutrophilic dermatosis. Like the classic example of neutrophilic dermatosis is Sweet syndrome, where cytokine-driven attracting neutrophils, to these lesions. Very often they are associated with myeloproliferative disorders sometimes even otherwise idiopathic. And you find a lot of neutrophils, little bit of leukocytoclasia. Here you find less of intact neutrophils, but more of leukocytoclasia. This is a typical leukocytoclastic vasculitis. So basically, the appearance of these cells in various settings, all of them are clues to diagnosis. So a careful reading of the type of cells that are present in the tissues gives you a lot of information. These are some examples of neutrophils in the tissues. Frank suppuration, microabscesses, mucosal, like gastritis and colitis active, vasculitis. Okay. Shall we go to the next case? Monica,
Yes,
are
sir.
you ready?
Yes, sir.
Okay, this is a female, 36 years, swelling left side of neck. Would you?
Sorry, it's a low power image, sir. Here I cannot comment on the native tissue, sir.
Okay.
At this power, I can see it's a hypercell. There are many of cells, sir, and there are giant cells also, sir. I can see giant cells also.
Groups of giant cells, isn't it?
Yes, sir.
Bunched together, groups of such giant cells. Some of them are quite big, large giant cells.
Yes, sir.
When do you find these large, very large giant cells? This is low power. I think this is almost scanner view. So in
Yes,
scanner view itself, you find the giant cell which is so long and big. And when do you find such huge, large giant cells? You can say whatever you want. Don't be diffident. See, giant cells, their cells are fusing together, trying to become bigger and bigger, trying to engulf something. And some things are too big for them to really engulf. So they go on becoming bigger and bigger.
Phagocytic.
Yeah, they're trying to phagocytose.
Phagocytic.
By cells themselves fusing together and becoming bigger to achieve this, but even despite that, they may not be able to. Some very large structures, like what? Foreign bodies. And anything else, any organisms sometimes. What kind of organisms? Which they will not be able to ingest.
Some parasitic.
Parasites, yeah, parasites, but obviously. And you find here a mixed inflammation all around.
Yes, sir. Here in this view,
And the type of cells?
Here, sir, in this slide, there are mixed inflammatory infiltrates, sir, comprising predominantly of plasma cells, eosinophils, and some neutrophils also there, sir.
Okay, so plasma cells and eosinophils.
Yes, sir.
These two are there. Then you have this very large giant cells.
Giant cells and
Immediately, what do you think of?
so according to these slides, I thought it as acute and chronic inflammation, most likely due
why
to
acute? Few neutrophils here and there. No.
yes, sir, mostly chronic inflammation due to parasitic or fungal origin.
Very good, very good. So the combination of eosinophils and plasma cells, plenty of eosinophils and plasma cells, particularly should make you think of
chronic
parasites.
inflammation due to parasitic.
Particularly parasitic. See here again you find lots of eosinophils.
Yes, sir.
So suppose you don't find any parasites. What then?
Maybe due to fungal, sir.
Will you give up?
No.
These are so many eosinophils. Yeah, some fungal infections do have a lot of eosinophils, particularly this nasal fungal diseases, rhino, endomophthalmomycos and all that. And in addition to that, some sections also show this somewhat cystic areas lined by macrophages. See?
Yes, sir.
This is again highly indicative that there is some parasite. So you should, when you see this kind of picture, keep on taking more sections, more tissue, process the whole tissue. So here, probably the diagnosis would be an inflammatory lesion, mixed infiltrate rich in eosinophils and plasma cells, few spaces lined by palisaded histiocytes, strongly suggestive of parasitic etiology. And you should try taking more sections. And in this particular case, this is what happened. When more tissue was processed, there was this beautiful nematode parasite sitting there, long parasite. These are multiple sections of the same. Can you guess what it is? Take a guess. What group of parasites? Nematodes. Tissue nematodes. Filaria. Okay. Which type of filaria most likely? So such thick muscle you can see. And this is the ovary with microfilaria. Thick muscle. This thick cuticular coat with slight corrugation. Okay, this is dirofilaria. This was basically a dirofilaria case, parasitic granuloma, dirofilaria. Okay?
Okay, sir.
So, eosinophils can be seen in many settings. Parasites, filarial tissues, you can see this. Then many inflammatory, allergic polyps, for example. This is a nasal polyp full of eosinophils, allergic nasal polyp. Or you can see folliculitis, eosinophilic folliculitis, which may be associated with various diseases, even HIV sometimes. Then you find what do you call this structures? This is a skin biopsy, and this disease is Wells syndrome or eosinophilic cellulitis. This is called. And what do you see? This what are these called? This eosinophilic material here, Anybody? These are called flame figures. Flame figures are just aggregated eosinophilic granules, And this is a very classic finding in some of the eosinophilic inflammations. And you can find plenty of eosinophils and other conditions like this, esophagitis. In reflux esophagitis, you find a lot of eosinophils within the mucosa. Many dermatological conditions, insect bite reaction, many other dermatological conditions. So there are many diseases. And eosinophilic enteritis or esophagitis or eosinophilic appendicitis, all these contain eosinophils in the muscle wall. That is again very characteristic. So, umpteen number of conditions, eosinophilic inflammation. So you should be aware of all these conditions. Okay, I think we'll go to this is a vasculitis. Vasculitis with infiltrating eosinophils. some types of eosinophilic vasculitis like Church-Strauss syndrome, where you find also granulomas sometimes. That's again very classical kind of finding. Shall we go to the next case, case number 3? And Ashok, can you discuss this?
Yes, sir.
These are just examples of eosinophilic. I won't go into this. You can look at the slide if you want. Ashok.
Yes. This section shows the partially effaced architecture of a lymph node.
Effaced
And,
architecture, if something is completely, it's something external, no? I would personally prefer effacement of architecture for something that is happening internally in the lymph node. Organization of the lymph nodal tissue, if it is altered, that is what I would call effacement. Not if a metastatic carcinoma completely fills up the node. I wouldn't want to use the term effaced architecture. It is no meaning actually. So similarly, this is something other than that. So this is a lymph node. What does it show? You can straight away call them granulomas, isn't it? Don't have to beat around the bush. Just say that you have multiple granulomas within the node. Okay, so let's look at these granulomas. What are the things that you would particularly look for in these granulomas when it occurs in a lymph node?
Multinucleated giant cells.
Okay, multinucleated giant cells. Maybe you will find here and there. Maybe other sections you will find more. Here there are some areas are full of multinucleated giant cells. What else would you look for in these granulomas?
For necrosis.
Necrosis. Especially central necrosis called caseating kind of necrosis. Eosinophilic, diffuse eosinophilic material, acellular or very sparsely cellular kind of material is very characteristic of what? TB. So any lymph node granuloma that you see, your first possibility would be, is it TB or is it not TB? In my younger days, we would diagnose any granuloma as TB unless otherwise proved, because tuberculosis was rampant, so common. But now things have changed. At least many parts of India, I think, other non-tuberculous granulomas are becoming much more common. At least in Kerala, that is what we find. Tuberculosis is becoming much rarer. Other non-TB granulomas are becoming more common. So whether there is caseous necrosis or not is something very terribly important. So that is what you should be looking at. And here you don't find caseation, but you find a little bit of fibrosis here, but not caseation within the granulomas. Here you find a little bit of acellular areas, small areas, Is it caseation or it is some fibrinoid kind of thing? It's difficult to say. And these are questionable to call them caseation, basically. I'll tell you what else it can be. And then you have these large giant cells. And some of these giant cells contain something. What is this?
Schwann bodies.
Okay. This is a calcified, concentric kind of bodies. They're called Schwann bodies. And very large giant cells. Does that make you think of anything in particular? Some disease?
Sarcoidosis.
Sarcoidosis. Definitely sarcoidosis.
Aravindan,
they used to be.
Aravindan, can I interrupt you? Some
please.
people have
Yes,
asked
madam.
for a laser pointer. So can you right click on the screen, please? And you'll see pointer options.
You can see
Thank
that
you.
now?
Yes, I think I can see it. I hope others can. Yeah.
Okay. So this is a shaman body. And here in this giant cell, you find another kind of body here. This is called an asteroid body. So shaman bodies particularly used to be, they used to say that it's very classic of sarcoidosis. But then some literature came that it can be found in other diseases also, and the importance, slowly fell away. But again, I think it has come back probably because it is more strongly associated with sarcoidosis than other conditions. Absence of caseation, all this should make you think of sarcoidosis in this particular case. So here the diagnosis we could give us granulomatous lymphadenitis. Please investigate for sarcoidosis. What are the kinds of investigations you would do?
Calcium levels and acetylcholinesterase
Yes,
levels.
ACE, calcium, chest X-rays. All these are helpful in looking for sarcoidosis. The macrophages are very, very heterogeneous kind of cells. You find all kinds of macrophages, some that form granulomas, the epithelioid kind of granulomas, some forming giant cells. Others are phagocytic primarily, non-secretory and secretory macrophages. So there are foam cells, lipid cells containing cells. There are large different types of macrophages are there that in itself is an entirely different topic. All of them have different kinds of metabolic pathways and activation and activities. So all these are important for you to understand and learn because all these can be seen in different types of inflammation. Primarily, granuloma is a collection of macrophages, and it can be epithelioid kind of cells, epithelial-like. Epithelioid is epithelial-like, flattened cells with more eosinophilic cytoplasm and closely touching each other, forming groups of cells like this are epithelioid granulomas. And there may be foam cell granulomas or non-epithelioid type of granulomas. Both can be seen. And epithelioid granulomas, there can be different types, caseous granulomas. There can be naked granulomas. Like in the previous case, you don't find a surrounding mantle of lymphocytes around the granulomas. So these are sometimes called naked granulomas, like in sarcoid or Crohn's disease. Pyogranulomas, as you see in fungal diseases, where you find in the center, you may find neutrophils. Stellate granulomas are large, somewhat undulated borders, epithelioid cells with neutrophils inside, as you see in cat scratch disease. Then granulomas with eosinophils, which can you see in parasitic disorders. So this is an example of epithelioid granulomas. This is a caseous granuloma, typical caseation necrosis. These are the naked granulomas that you see in sarcoid or Crohn's disease. This is an example of intestinal tuberculosis on one side, where you find large confluent granulomas in tuberculosis. It's not seen in Crohn's disease. And small, discrete kind of granulomas, which are seen in Crohn's disease. So all these different features of the granulomas itself helps you to make differential diagnosis between different conditions. And it's extremely important to do to prove that something is not tuberculosis. Very, very important, because missing a case of tuberculosis, delaying the treatment is not really good at all. So AFB stain should be done in all cases of granulomatous inflammation. And surprisingly, if you diligently do the staining and diligently search for it, many cases you do find acid-fast bacilli within in the tissue itself. And nowadays we also have the option of sending a little bit of tissue, or sometimes even the blocks, though blocks are not that satisfactory for PCR test for tuberculosis. So both these, if possible, do a PCR, always do an IFB to rule out tuberculosis. The previous case that I showed, it was not there, it was not positive. You find a nice asteroid body and a Schumann body, which if you see, should definitely make you search for sarcoidosis. And in the case that I showed you, it was investigated for sarcoidosis and turned out to be sarcoid. Okay, next case, Niyati, will you discuss?
Yes, sir. So here I can see from the sections studied, there is a synovial lining, which is hyperplastic.
Let's say it is somewhat cystic kind of lining. Let's not call it synovial lining, really. I'm not really sure whether it is synovium. It may be synovium, but it is definitely something cystic, isn't it? Because you find long, kind of cyst wall kind of structures, thinned out, elongated. So let's call it a cyst rather than synovium. It may be synovium, may not be synovium. Right now.
Okay, sir.
Okay.
So this is a cystic wall lining, and I can see there is a lymphoplasmacytic inflammatory infiltrate within this. And there is also hyperemia at a few places. Which
Should I go to the next slide?
Yes, sir. So here also there is a dense lymphoplasmacytic infiltrate, and apart from that, I can also see there is some fibrin deposit.
Okay, very good.
In this also, so there is a lymphoplasmacytic infiltrate in this slide.
What is this? What do you think is this? Yeah. Are you just saying that synovial cells or something else actually? These cells, or lining the inner part of the cyst, I would believe.
Yes, sir.
This is the higher power of that cells.
So this could be.
No, there's a complete lining here.
Could it be histiocytes?
Could there be macrophages?
Yes, sir. This could be macrophages.
Epithelioid or rather macrophages. So basically, these are lined by macrophages, palisading. They're palisading macrophages. So this is a cystic space lined by palisaded histiocytes. So when you find something like this, what should be your impression basically? What are the possibilities you would think of?
Sir,
there aren't many eosinophils, no? So
No,
if
sir.
eosinophils were also there, I would definitely think in terms of parasites.
Yes, sir.
But in the absence of eosinophils, here in this case, what will you think?
Sir, this could be the case of rheumatoid arthritis due to the fibrin deposition and lymphoplasmacytic infiltrate.
So it could be
Rheumatoid arthritis.
rheumatoid arthritis. So before that, would you want to carefully look at the slide, various parts of it, or do special stains? Any special stain that you would do? You would definitely
GMS or
GMS and PS, because fungal infections you have to do it. Okay.
Yes, sir.
Particularly in this location, elbow, knee, below the popliteal region, all this region, fungal infections, particularly the bursal infections, fungal bursitis is quite common. And so you do a GMS, and this is what it shows. Okay? So this turned out to be a fungal bursitis. So again, the tissue pattern should alert you, because sometimes you can see the fungi even in the HND. But frequently in fungal bursitis, you don't see the fungus with an HND. But when you see a GMS, you do a GMS, you find this fungi beautifully. So the tissue pattern of this palisaded histiocytes should alert you, and the cystic kind of structure should alert you to the possibility of fungal infection. So I think we'll go to the next question. How am I doing for time?
No, you're doing well. Continue.
Okay. So this will be discussed by Vishnu Priya.
So this is local view of probably renal tissue displaying glomerulus and tissue,
Okay.
and there is increased inflammatory cell infiltration.
Okay. Would you be satisfied just calling it inflammatory cell infiltrate, or are they more organized?
Organized.
They're very organized, isn't it? They are just collections, groups of cells like this. Groups here.
Yes, sir.
Okay, let's see under higher power. So here it is. They are undoubtedly granulomas.
Granulomas.
No doubt that they are granulomas, and many of these granulomas have in the center, what is this?
Necrotizing granulomas.
Necrotizing granulomas. Necrotizing, a better term, and this neutrophilic. See, look at this granulomas containing abscess-like structures inside, isn't it? So this is a large granuloma and full of neutrophils inside. This is a higher power view, the epithelioid cells here, and full of neutrophils. So what further investigations you want to do? Any special stain? So what's your provisional impression?
Granulomatous pyelonephritis.
Pardon?
Granulomatous pyelonephritis, sir.
Granulomatous pyelonephritis. Okay. This is not exactly in the pelvis, no? They're seen all over. Cortical tissue is mostly it is the cortical tissue that is involved. And when you see a granuloma like this, with neutrophils inside, you should always think of organisms that is producing this. So what kind of organisms will you think of? These are the, one is fungal organism. So you do a GMS and PS. And of course they were negative. GMS and PS were negative. What else? See this large granuloma, sometimes with an undulating border. It's not come very nicely here, but some of these slides it is come, like this. These are called stellate disease. Stellate granulomas. And stellate granulomas makes you immediately think of, somebody was saying that?
Cat scratch disease.
Okay.
Bartonella.
You should think of cat scratch disease as a possibility, or bacterial infections. So what kind of special stain would you do? What is the special stain? No? Okay, it's not very commonly done, but it is very, very useful to get the Warthin Starry either prepared in your lab, or you can buy it also now. You can get it straight away. And the Wathenstari stain was done in this particular case, though it was not a lymph node, because it was so typical, because its fungi were all negative. We did a Wathenstari, and you can see this bacilli here. What is the bacilli that produces, that's responsible for cat scratch?
Bartonella henselae.
Okay, Bartonella henselae. So these are the organisms seen in this case, and indeed there was history of exposure to cat and all that when we inquired in the house itself, and this was treated with antibiotics. Okay. I think you can, we have 7 cases and only 6 percenters. So Vishnu Priya can discuss the next case also.
Yes.
This was the diagnosis. And stellate abscesses like this can be seen in cat scratch disease. Not only cat scratch, but it is very classically seen also in lymphogranuloma venereum. Fortunately, something not very commonly seen now.
Aravindan, we've
Yes.
lost your, you'll have to share the video again because we've lost the video.
Okay. Can see now?
Yes, you need to make it full screen. Yeah, good.
Okay, so lymphogranuloma venereum is another possibility. Fortunately, not seen much now. Tularemia, sometimes I've never seen case of tularemia. A typical mycobacteriosis. Sometimes you can find the same kind of granulomas. That is a possibility you have to always think of. Yersiniosis sometimes in the intestine and other tissues can show this kind of granulomas. Okay, so next case. I think Vishnu can do this also.
This shows fragments of fibrocollagenous tissue with dead and viable bones, sir,
Okay.
along with inflammatory cell infiltrate.
What is the predominant finding here in this slide? Inflammatory cells, yes. And inflammatory cells and
Fibrosis.
fibrosis. Okay, I'll go. Fibrotic tissue like here. Okay. So inflammation and fibrosis. So let's see what is the predominant type of inflammatory cells. Again, inflammation, fibrosis.
Predominantly plasma cells, sir.
Okay. So fibrosis and inflammation, predominantly plasma cells. What are you going to do? What would you like to do next? Whenever you see lots of plasma cells,
Evaluate for multiple myeloma.
okay, definitely. So you think of a plasma cell dyscrasia. For that, what do? You can do for one, you can do an immunofixation test to see if there is a monoclonal gammopathy. And here in the right in the slide itself, you can stay in it for clonality, isn't it? we can look whether it is kappa lambda to find whether there is a restriction. So in this case, at least the electrophoresis, immunofixation, everything was negative.
Okay.
So what other possibility would you think of when you find a fibrotic lesion, lot of fibrosis, with lot of plasma cells?
Plasma cell
And
also
incidentally, the serum gamma globulins were high, but they were polyclonal.
osteomyelitis.
Pardon?
Plasma cell osteomyelitis.
Plasma cell osteomyelitis. I am not really very familiar with that condition. Any kind of osteomyelitis, you can see some increased plasma cells, but this degree of osteomyelitis, other types of inflammatory cells are not there. Then you don't find the typical other features of osteomyelitis, like dead bone. Anything else would you think of? When you see a lot of plasma cells, increased gamma globulins. Anyone can answer? Anybody? Any particular subset of gamma globulins increased? Any particular subset of immunoglobulins increased?
IgG4 disease.
Yeah, exactly. So you have to think of IgG4 disease, in such cases. And IgG4, it can affect the spine, can affect produce spondylodiscitis. And in this particular case, unfortunately, the serum IgG4 was increased, but I couldn't, so far, this is a new case, so I have not been able to get the IgG4 immunohistochemistry done because the patients went somewhere else and I didn't get the feedback regarding this. But I strongly think that this is, see, this kind of fibrotic lesion, sometimes storiform fibrosis in some areas, suggestive of IgG4 related disease. So I think we are coming to the last case. And Lamia,
Yes, sir.
Fatma,
Yes,
can
sir.
discuss that.
Yes, sir.
And just before that, plasma cell rich infiltrates can be seen in many diseases. Sometimes along with granulomas, when you find lots of plasma cells, you should always think of leishmaniasis, particularly cutaneous leishmaniasis. You find lesions, patients, at least in Kerala, we have most of these patients coming from the Gulf and few isolated pockets near forest areas. I believe that it is common in certain parts of Western India also. So cutaneous leishmaniasis, you find lots of plasma cells. Of course, the visceral leishmaniasis, it's not a difficult diagnosis that way. Rhinoscleroma is a condition where you find lots of plasma cells with Russell bodies. Brucellosis, syphilis, particularly when you find plasma cells tightly clustered around blood vessels in a coat sleeve pattern, then that you should alert you to syphilis. Recently, we had a case of secondary syphilis. Everybody had thought that all the secondary syphilis and are all a long and forgotten disease, but histology was so suggestive because of this plasma cell infiltrates around the vessels with small granulomas. And it really turned out to be a case of secondary syphilis. The clinical picture was also very typical actually, but the clinicians have forgotten about secondary syphilis because they hardly ever see it now. Then IgG4 disease, some helminthic infections along with granulomas and eosinophils as we discussed earlier. Okay. Lamia?
Yes, sir. In this image, I can see the sections from lung show inflammatory cells, and there is diffuse alveolar damage.
Are they inflammatory cells?
Some Mason bodies.
Mason bodies are more tighter, round bodies, no? But you're coming closer. What are the cells that you see here inside the alveoli? They don't look like inflammatory cells, no?
No, sir.
So
Fibroblast?
Yes, sir. Fibroblast.
fibroblasts, yeah.
Yes, sir.
Fibroblasts and myofibroblasts. They look like fibroblasts or myofibroblasts. Few RBCs are seen here. There is definitely diffuse alveolar damage. And here you find this all kinds of, in other settings, you would think they are very bizarre kind of fibroblasts, some other tumors and all. So you find, so this is again some kind of operative kind of process going on, isn't it?
Yes, sir.
So inside the alveoli, fibroblasts within the alveoli, this destruction of alveolar lining, and cells in the alveoli are fibroblasts. Where are they from? The process seems to be alveolar destruction, fibrin, macrophages, fibronectin, and alveolar lumen, migration of fibroblasts from the alveolar wall, producing intraalveolar fibrosis. So what are the possibilities?
Organizing pneumonia.
Something, yeah, it is an organizing lesion. Whether you want to call it organizing pneumonia, something similar, something getting organized, yes. So this kind of intraalveolar fibrosis you can find in some hypersensitivity pneumonitis, the classical organizing pneumonias, chronic organizing pneumonia, what used to be called BOOP, acute fibrinous organizing pneumonia, where you find a lot of fibrin, find much more of fibrin along with this organization with fibroblasts. And yet another lesion is paraquat poisoning, where you find this very typical kind of picture. And this was a farmer who had committed suicide by drinking paraquat. So this was what it was, a case of paraquat poisoning. So I think this is the end of the slides. And just one message that I really want to convey with this slide seminar is that histology, by looking at the different type of inflammatory cells, the patterns of inflammation, the patterns of granulomas, all these actually give you clues to not merely just histological diagnosis, but also to the etiology. And you should not stop at giving just a histological naming something as a pneumonia or whatever, but also go further and try to find the cause, what it is due to, etiology. And plenty of pointers to the etiology are available even in your histological sections. So you have to be, as pathologists, we need to be very active in trying to find out real cause, the ultimate cause, so to speak of, rather than just give a sign out a report and be finished with it. Okay. Thank you very much, all of you.
Thank you, sir.
Thank you, Aravindan. That was really a whole, it was like encompassing all of the different processes of inflammation, acute, chronic, as well as, granulomatous disease and other reactions, which I think were repair as well in the context of these 7 cases. Thank you. That was really, I think, very useful, or should have been very useful to the students. I'm also very happy that the students did a good interaction, which, I think is useful, because when students interact, they're interacting also on behalf of all of the the others who are watching and listening to the slide seminar. Now would Mamatala or Pooja want to take some of the questions that have been asked in the chat box?
Yes, ma'am. I'll take the questions. So the first question is it correct to call it granuloma if there are no epithelioid cells? Because as per definition of granulomatous inflammation, it is aggregation of modified activated macrophages or epithelioid cells.
Yeah, I think it is an organized collection of histiocytes is what I learned as a granuloma. But people give all kinds of definitions, and some people say that only epithelioid cells constitute a granuloma. But I personally, I would like to call any collection of histiocytes as granuloma, and specifically say that epithelioid granulomas as the ones with epithelioid.
Yeah, I think that you're right, Aravindan. I use the term granuloma much more generally, because otherwise, how would you call something a lipogranuloma? There are no epithelioid cells in a lipogranuloma. There are no epithelioid cells in lots of granulomas. The only thing about a granuloma is that there should not be sheets of histiocytes, because the word oma is given to something which is a circumscribed collection of anything. Okay, that's why we call things tuberculoma and so on, because oma really means that there is a small or large collection which has a circumscribed edge. So I think that sheets and sheets of histiocytes don't constitute a granuloma. It must have some kind of circumscription to it. So and for me, I agree with you, Aravindan. Anything is a granuloma if it has, it conforms to this circumscription definition, and it consists of, you can call them histiocytes, you can call them macrophages, whatever. And epithelioid cell granuloma is one type of granuloma. So I agree with you. Any other questions?
Yes, ma'am.
Yes, I think.
How to differentiate between tuberculosis and Crohn's disease on a colonic biopsy, especially if there is no caseous necrosis?
No, what I heavily rely upon is the size of granulomas and whether they are confluent or not. When you have larger sized granulomas and when there is confluence of granulomas, and another point is that when it is towards the surface and when it is seen in an area of ulceration, a granuloma seen in the area of ulceration, all these are pointers to tuberculosis rather than Crohn's. In all cases, I would like to do an AFP strain also.
Next question is, what was the clinical presence?
1 minute. Can I just ask Aravindan, what if you have, the terminal ileum that is showing you the granuloma? The patient is complaining of pain and there are some obstructive symptoms and in the right iliac fossa, and it's the terminal ileum that shows it. What would your bet be on? Would you make in such a situation? Would you make a diagnosis of Crohn's disease? I don't. That's why I am asking you.
No, previously, all such cases I would straight away have called tuberculosis. But nowadays I am more cautious because tuberculosis is becoming rarer, Crohn's is becoming much more common. So much so that many of such cases, as you described, primarily involving terminal ileum, turn out to be Crohn's finally. So I'm not as biased towards tuberculosis as I used to be before.
All right. This is what I would also like to, sort of just have a little debate on, Aravindan. See, you said something during your talk that tuberculosis in Kerala is going down and sarcoidosis is on the rise. Okay, now the same thing you are mentioning as far as tuberculosis is on the wane in the ileocecal region and sarcoidosis is on the rise. Not sarcoidosis, sorry, Crohn's is on the rise. And I would like perhaps to think of this as a change in the immune status of the individual and perhaps the bacterium having got, having quite a different effect on a herd immunity. It's not just the individual but the herd, and it's interesting that in Kerala, where you have much better nutrition, the whole system, the whole population is a different kind of population, that you are seeing on a phenomenon that used to happen in the West. But you get, as tuberculosis wanes, sarcoidosis comes up, and that tells me, and the same thing for an immunopathy like Crohn's, it tells me that it may be the same organism but a different immune response. So I am not willing to buy that we have got rid of Mycobacterium tuberculosis. We have just modified the herd response to the same disease. How you treat it is a different issue altogether. But I'm talking about etiopathogenesis.
Madam, one objection to that would be that many of these cases, almost all cases nowadays, we do AFP and PCR. So
I
all
understand.
cases of tuberculosis where it responds to treatment, PCR comes as positive, or many cases, I wouldn't say all because there are many false negatives. PCR comes as positive, and others the PCR is negative. So I really wouldn't think now that it is the same organism.
Yeah, no, what I'm asking Aravindan is, what is, are you doing PCR, or are we doing the quick test? You know what you call, you're doing the quick, or you're doing a complete PCR?
Both are being done. Both are being done.
Both are being done, but most people just do the quick,
Yeah.
the quick test, and that doesn't tell you anything. It works for lung in general, for mycobacterium in the lung, and I have a suspicion that it is the same thing for a PCR.
But see, madam, at least few cases of a classic Crohn's. Classic Crohn's, unmistakable classic Crohn's. At least a few cases should be TB PCR positive, which is not happening.
No, it's true. I'm not talking about Crohn's in general. I'm talking about ileocecal granulomas. And that is where I am a little, suspicious. When, yes, you have classic Crohn's, even that we don't know what the inciting agent is. But I feel that
some cases, even it could be even Yersiniosis. We really do not know because we really do not test for Yersinia.
That's
some of
right.
these cases of terminal ileal lesions, sometimes I have really had suspicion it's Yersinia. It's not fitting into anything else. Some histological things, like this, like typical ulcers, but we don't test them.
Oh, I agree with you, and I think that there is more to than what meets the eye. I also would like to caution people. For a long time now, I have not called granulomatous disease. I do everything. I do the AFB, I do the fungal stains, and in some conditions also do I have stopped calling anything granulomatous disease, even if it has some amount of caseation, Mycobacterium tuberculosis. I don't call it tuberculosis. I call it mycobacterial disease, because I have found that some of these things, even with caseation, have grown atypical mycobacteria.
Definitely.
So this is what the message that I want to give to all of those who are listening. Caseation does not equate with M. tuberculosis. So please don't use the word tuberculosis, because the treatment of atypical mycobacterium is very different from the treatment of tuberculosis. You don't use the same drugs, etc. So if you say, with the weight of your histopathology, and you sign a report of tuberculosis, you are actually suggesting that this patient go on M tuberculosis treatment for M tuberculosis. So I say that this is mycobacterial disease. I do it even if I find AFB, because AFB can be long, short, beaded, not beaded. It all depends on the immune status of the individual and whether the AFB are very fresh and happy or not, as the case may be. and I ask them to look, get the the microbiological investigations done. If it is classical and you have a lot of caseation and maybe it's ileocecal, it's unlikely to be anything else but M. tuberculosis. So maybe in such an instance, it's the clinician decides that he has to do this. But in lots and lots of other places, I am very, very careful not to say, even if I see caseation, because lymph nodes, it's being grown out of other things, and it is not M. tuberculosis, it is something else, cancer or, avium or something. And worse, I mean, of course, if it is a patient with HIV, then there are no bets. All bets are off because you can get almost any other mycobacterium in such a case. That's all that I wanted to add to this particular discussion. All right, any further questions?
Yes, ma'am. In the last case, if there is no history, can it be called acute phase of diffuse alveolar damage?
With organization. With organization and fibroblasts, yes.
Yeah. I think that, students are not terribly aware of what organization is. And organization does not happen just in inflammation. I don't know if anybody would like to, take the question as to what organization is, because it's a reparative process. Okay, and I'm not sure, Aravindan, I haven't read the general pathology textbooks, not recently, maybe you have, but the word doesn't even pop up because I ask so many students, can you tell me what organization is? And I find that the word is alien to many students. Can I ask the five students over here? Ashok, have you heard of the word organization?
Yes, ma'am.
Can you tell me what is organization, Ashok?
Collection of the exudates along with the neutrophils and other.
No, that's not organization. Let's ask somebody else. Vishnu Priya, what is organization? You heard the term, Vishnu? No? Okay. What about Monica? Have you heard of the term organization?
Yes, ma'am, I have heard.
Yeah, can you tell us what it is?
Collection of fibroblasts.
Collection of fibroblasts. So any collection of fibroblasts you would call organization. Niyati, you've heard the term? No? No. Okay. Who else was there today?
Ankita.
Ankita, yes? Ankita, are you there or have you left? Perhaps she's left.
She's on mute actually.
She didn't turn up. And what about she was very active, this young lady from Nepal.
Yeah, she is Ankita, ma'am.
She's Ankita. So
yeah,
maybe
she's put on mute, so it's locked. Ruchi will have to help her.
Okay. Anyway, I think all of you should just go and I don't even know whether the term appears in your textbooks. Okay, so maybe you don't understand, but we use the term reflexly. Okay, Dr. Aravindan used it. I realized that many kids nowadays don't know what organization is, and it is a reparative process in which whatever the acute process was, it could be it could be hemorrhage, it could be inflammation, it's of any kind, like you saw organization here in this last case. It could be an abscess, an acute process in which you have lots of neutrophils. But when repair occurs in this and an attempt to contain what that particular process is, and then repair starts, is what organization is all about. And the word organization is an interesting word, organ, that means it is trying to get that tissue or that particular area back to its original sort of form. That is probably what the meaning of this term organization, because it doesn't form an organ, certainly not, but it tries to get back to the original form before the process actually occurred. So please, all of you who are listening in, go and read what is organization and wrap your heads around it, because that is how repair happens when it is within a tissue. Okay, you don't call a surface thing like an ulcer, although it is repair. We don't normally use that term organization of an ulcer. Okay, but we do it for hemorrhage, we do it for a thrombus, we do it for localized lesions within tissues, not on surfaces. Okay, so there is a subtle language that pathologists use, and I think you're becoming pathologists, you're budding pathologists, so you should also learn the language that we use. Otherwise, what do you think is the problem, Ashok? If we don't know the language that pathologists use, what can happen, Ashok? It would be like me trying to understand, Malayalam, or even lose the subtleties of Marathi. I live in Mumbai. I speak Marathi, but I am not going to be I would not be able to understand the subtleties of a novel that is written in Marathi. So if we need to understand the subtleties of our the language that we as pathologists use, then we must have a ear. If you have a ear for a language, and if you heard a word that you haven't heard before, or you're not sure what it is, ask or go and read. Yeah, that's what I would say. Because, Aravindan, we use terms, and I'm not sure whether the youngsters nowadays actually understand what we're saying. Okay. Any other questions?
In a case of granuloma with AFP, I think you addressed this, but still, I'll just read it out. In a case of granuloma with AFP positivity, should we write tuberculous granuloma or just granulomatous lesion with AFP positive?
I think
my practice is to use the term tuberculous.
Okay.
So far, because many clinicians would like more positive kind of diagnosis, otherwise vague things they are not happy with.
No,
because
I understand.
Then the decision is thrown to them. So they would like that. But Madam said that there are cases where atypical mycobacterial, particularly cervical nodes.
That's it.
Cervical nodes, the atypical mycobacterial infections are far more common than other places. In a GI lesion, I don't think it is very common, but cervical nodes and the upper respiratory tract origin, atypical mycobacteria are common. Different places, the different studies say different things, but anything up to 20% can be atypical mycobacteria.
Yeah, so that's the reason I say that even if you see caseation, be a little careful about calling something tuberculosis. I don't do it in my practice. And there is a very naive belief amongst clinicians that if, they have got a report of granuloma and they want to know whether this is a non-caseating mycobacterial disease or sarcoidosis, that histopathology is going to solve their problems. And it doesn't solve the problem, unless, yes, you find some AFB by very diligently looking at, which I do very diligently, but it's not very often that in a non-caseating situation that you find AFB. Every now and then, yes, you do, but otherwise, no. And it's very...
My only hope is that in the coming 1 or 2 years, possibly, or even a little more, genomics is going to answer these questions much better than PCR.
I hope
if
that
you can
it does,
do
and it becomes
the larger areas of the genome, then you can very easily say it is MTB or other.
Yeah, that's right. I think that at the moment we are not there, and I feel that ultimately it is the clinician who has to make up his mind, whether he should do one or the other, and And certainly in certain situations like HIV, I wouldn't bet on, whether this is TB or not TB, and it makes a hell of a lot of difference. Okay, any other questions?
Yes, ma'am. At some sites like pleural peritoneal cavity, if organization occurs, it obliterates the cavity and is hence unfavorable.
Yeah, everywhere, mostly, very frequently, organization may not always be, because it is reparative doesn't mean that it is good. It can actually be quite harmful. Like in the lung, the case that we saw here, it really damages the lung even further. Fibrosis can damage, huge damage. So it's not, may not be helpful always.
Okay, ma'am. That's all.
Yeah, that's right. Just to say that they thought that, it's trying to form an organ. It tries to do many things. Repair tries to bring you back to as near normal as possible. But it can't in many cases. Have you seen patients who are scarred from burns? That is organization, okay, and repair. But it never is able to, quite often, if you've got deep burns, you never get complete restoration to normal. So that's right. Okay, thank you so much, Aravindan, and thank you all the students over here. You've been very cooperative.